Let's give her a round of applause. Judy Morh Peterson, Director of MedQuest. Come on up.
Well, thanks so much for everybody hanging out to the end of the day. I know it's been a full day and a long day, and it's actually quite impressive that there are this many of you who are still hanging out to hear this. And so I am going to try to share a little bit about where we as a Medicaid program are hoping to go, and the rationale as to why, and what we hope to accomplish and what we're going to ask of you. So first of all, I just wanted to outline for the MedQuest, we're very proud of the fact that we just redid and updated our mission vision, which is that the people of Hawaii embrace health and wellness. I love that because it matches right up with the overall vision that I share with my colleague, Dr. Pressler at the Department of Health. And then I also love our mission, which is to empower Hawaii's residents to improve and sustain well-being for developing, promoting, and administering innovative and high-quality healthcare programs with Aloha. And then just so people know, because I didn't know this when I first got here 2.5 years ago, that QUEST is actually an acronym, and so now you have the acronym. So there you go. Okay, so some very fast facts about our Medicaid program and about Medicaid. You know, oftentimes I do these talks and then I get to the end and I get asked, well, I really appreciated it, but what's the Medicaid program? What is Medicaid? And I go, oh, shoot. I have to back up a little bit. So I just wanted to very, very briefly say that Medicaid is health insurance for people with low incomes. And it provides a full range of health benefits. And we also cover long-term supports and services. Nationally, there's over 70 million people who are covered by Medicaid. It's actually a larger program. It covers more people than Medicare, that other MEDA program. And it covers 40% usually of all the Medicaid costs. About 40% of it is for long-term supports and services. Those are things like nursing facilities, adult residential homes, for programs for our kapuna and people with disabilities. So it's a very, very broad program, and it's actually a very, very large program. Many of you actually probably may have heard a lot more about Medicaid this past year because it's been in the crosshairs of the federal Republican Congress. So that has been a lot of fun this past year. So we here in Hawaii, we cover about 1/4 of the state's population. I'm just going to stop there. 1/4, 25% of the state's population, and over 40% of all the children in this state are on Medicaid. We do run a program that uses what we call an 1115 waiver. What that 1115 waiver means is that it's like our contract that we have with CMS on how we operate our program. And the 1115 means that we can run it differently than what the standard Medicaid rules are. The CHIP is part of our Medicaid program. And our delivery system is nearly 100% managed care. And we have a mental health managed care carve-out for specialized mental health services. We have dental, a very limited adult dental benefit, much to my chagrin. I was hoping that we would get it, but if you can advocate for that, we would all appreciate that. And it is entirely fee-for-service. So not all Medicaid individuals are the same. We have about the same number of children as we do adults. And then that bottom number on the right-hand side, the right-hand column, that's about 50,000 individuals who are aged, blind, or disabled. And as you can see, there's 50,000 of them, but they make up a lot more people proportionately when we're thinking about costs. So, and children, that's that top color there, they're more people, but they don't make up very many costs because children don't have as many healthcare costs. That makes a difference when you're trying to work on saving costs, or you're trying to make changes in your healthcare delivery system and you're trying to figure out, well, where are we spending the money? Then it's a good idea to remember that it's with the aged, blind, and disabled population, and that if you make changes there, it's to a very, very vulnerable population. And that you have to pay attention to that and be very careful when you're making those changes. So as I mentioned, we have a managed care enrollment. For our state, we have 5 different health plans: United, Ohana, Kaiser, HMSA, and Aloha Care. HMSA is by far the largest. However, United and Ohana cover the bulk of our aged, blind, and disabled population. So now I'm going to move to, that's a little bit about us. Now I'm going to move to why it is that we're paying attention to this. And I have to say that when I first started working on this, when I first became Medicaid director back in Oregon, way back in 2009, this was all new. People were not talking about the cost and the value of healthcare. But now, it was at every single session that I attended today. And so this is really, really well known. And yet, we keep talking about it, but now we're gonna have to take some action. So this is just some more documentation, some more information. I got this slide from Commissioner Ito's, what he dubs his gloom and doom presentation. This slide demonstrates that essentially healthcare costs are becoming an ever-increasing portion and proportion of people's wages. So if we think about medical expenses and healthcare inflation over time, I mean, I know the cost of living is high in Hawaii, but it's not like this. But yet, this is what we're facing. And this, by the way, I know you probably can't read the little teeny tiny print there, but this is from 2007. So if I were to recalculate it, those numbers would be even higher 10 years later. So just think about that. You go in and you go to buy a dozen eggs, and you pay $80. Those are the healthcare costs in our country. Yet for everything that we spend, our outcomes and our basic health outcomes and our overall health does not reflect the amount of money that we spend. So this is an example, and these are from my colleagues at the Department of Health. What you see is the ever-increasing rate of obesity. So the good news is, which was on that first slide, Hawaii is one of the healthiest states. We have one of the lowest obesity rates in the country. But that's like comparing the worst in a worst environment, right? Oh, yay, we're the best in the worst, right? Right, our rates of obesity are going up rapidly, and that has huge implications, pun intended, for our healthcare system and healthcare costs. For example, diabetes, direct connection between those two. 1 in 2, 50% of the adult population is either at risk, prediabetes, or has diabetes. We wonder where our healthcare costs are going. Just think about dialysis centers, think about chronic kidney disease, renal failure. 1 in 3 has one of these complicating, serious health conditions. This is here. This is in one of the healthiest states. We're number 2. We had been number 1, but we're number 2 in the country. Pretty staggering, right? But, and again, I took this slide from the Department of Health. Health is everyone's kuleana, right? It's all of our business, and we can do something about it. How do we make health Hawaii's shared value? How do we just say, hey, we're the healthiest in the country? How do we say we're the healthiest? What do we want our communities and our healthcare system to look like? How do we want to invest the amount of money that we spend? So we are due in the Medicaid program to renew this 1115 waiver that I mentioned earlier. It comes up for renewal every 5 years. And so we've dubbed this our HOPE project. We're calling it the Hawaii Ohananui Expansion. Ohananui, I'll talk a little bit more about that momentarily. And what we would like to do is create a 5-year roadmap in working with all of the partners to accomplish both this goal of healthy communities and healthy families, but within the healthcare using what's known as the triple aim: better care, better health, and sustainable costs. We'd like to do it by aligning to this common framework. There's a lot of words there. I'm hoping you can read it. But essentially what it's saying is we need to take a look at the whole family, the whole community in culturally appropriate ways over the entire life cycle to be able to focus on improving community well-being, family well-being. In order to accomplish that, we've outlined these several different aspects for innovation. I'm not sure you can read how well you can read that. There's a lot of words on this page, so I do apologize for that. But the top one there is that I don't want to lose sight of. Actually, we had dropped it out of an earlier version of our vision document. But this is actually fundamental as well. While we're working on innovation, we also cannot lose sight of the importance of people maintaining access to health insurance. That's only the first step. It doesn't guarantee, quality care or health outcomes, but it sure as heck is necessary in order to accomplish those things. So we can't lose sight of the fact that no matter what we do, we also need to continue to make sure that we have continued access to health insurance and health care. We also want to use an emphasis on a whole person, whole family approach over the whole life cycle. We call this, part of that approach is something that we at the Department of Human Services, Department of Health, and other state agencies call our Ohananui approach, which is to focus on young children and their families in a multi-generational way to address those families' needs. It's not okay to just focus on the child, and it's also not okay just to focus on the parent. You actually have to consider the family together, that child together. And you also need to invest early and concurrently in those children and their families. The earlier, the better. We also need to address the social determinants of health. I'll talk a little bit more about that momentarily. We need to emphasize health promotion, prevention, primary care, and behavioral health integration. We need to focus on system-wide changes, not nibble around the edges, but we actually need to take on some big system changes. And we need to leverage and support community initiatives that are already going on. So what does it mean to have whole person health? Our whole entire healthcare system is set up that divides the body up into various different pieces, right? Chops the head off from the rest of the body, treats the mouth as if it weren't connected. We treat behavioral health. In fact, behavioral health, a lot of those providers, that's a completely different delivery system that doesn't even talk to the physical health care or the acute care health side. And it's all arranged around body parts and around diseases, not around a person. And the fact that we are all integrated human beings. We're in one body, we're integrated in our social networks and within our families and within our communities. So if we want to take, one of the approaches that we need to think about is taking this whole person health approach as an integrated from both the provider perspective as well as from the person perspective. again, for all our focus and money that we spend on the healthcare delivery system, which is that little focus there on medical care, that little pie, that's just 10% of what drives overall health, just 10%. The rest are the choices that we make about our health, lifestyle behavior. It's about other social determinants of health, economy, education, poverty, employment, where we live, work, and play. It's about our environment and our other social networks. So if we really want to make a difference, we need to shift our resources from that 10% location of effectiveness, and we need to focus on those other areas. How do we do that? Well, it means that we have to think about our services, and we have to think about health, and we have to think about community well-being from this kind of perspective and not from just a healthcare delivery system perspective. Yes, we have to make changes in the healthcare delivery system, and that's primarily where Medicaid works. But we also have to make those changes, and we have to work and integrate with public health. I was on a panel earlier with Dr. Pressler and other colleagues about improving public health, and they're totally one and the same. We have to be joined at the hip. We have to be working together. But it goes beyond that. It actually goes on to working with and investing in social services and community services, housing, education, employment. That's how we make a difference. So this is a one-page handy-dandy summary of what we're proposing for our HOPE and for our 1115 waiver renewal. This is part of a larger vision document that I'm happy to share with anybody who would like it. If you just give me a business card or something and put vision document on the back, I'd be so happy to send it out to you. We want to hear back from all of you. But in general, our overall vision, our overall goals for this triple aim and for accomplishing healthy families and healthy communities is to focus on 4 different strategic initiatives. There's a long-term investment strategy, a short-term investment strategy, paying for things differently, and then focusing on the community. So the long-term investment strategy is by investing in primary care, health promotion, health education. Short-term investment strategy is by improving outcomes and improving care for people who have very complex health needs. The third, in order to make that happen, you have to change the financial incentives. This cannot be done if you don't change how it is that you pay for healthcare. And then the fourth is to support those community initiatives to promote community well-being. We figure that there's some basic foundational building blocks that have to be accomplished in order to do these 4 strategies. It needs to be using health information technology to drive transformation and information, increase workforce capacity, improving performance measurement and evaluation, accountability, and transformation. So I'm going to go over each one of these pretty quickly here. So first of all, investing in primary care. So we want to improve health overall through primary care. Why? Because that's where it makes the biggest difference if you can catch it early, right? It also will allow us to have sustainable costs over the long run. So we have several different initiatives underneath of that big one, proposed priority projects. So one is by increasing or probably mandating, saying that we expect an increasing amount to be spent on primary care and health promotion and education. We want to look for different ways of paying for that, using for those evidence-based models. This is also bringing in support for behavioral health. That's, again, there's a huge disconnect there, and we desperately need to bring those 2 systems together, provide much stronger supports for primary care so that people's behavioral health needs aren't being shunted off And by doing so, it's actually having a dramatic impact on their physical side health outcomes. So we're looking at the possibility of how we could pay for and reimburse psychiatric hotline services, Project ECHO, which is consultation, the promotion of the screening, brief intervention, and referral for treatment, which is for substance use, and then developing a health equity plan, because not everybody's health needs are the same, and they actually vary dramatically among different groups. This is an example of working with the Department of Health and the kind of idea that we would like to promote and do more of. This is a campaign that's going on right now for getting screened for diabetes. Now, obviously, we want to move even further up and promote things like physical activity and nutrition, et cetera, so that we're not just screening for diabetes, but if, the sooner you can have people start to make those changes, or that we need to start making changes in our lives to live more healthily, the better off we are. We also, in investing in primary care, we want to focus on children. So we want to promote screening for young children, developmental and behavioral health. Again, the sooner and the earlier you can do these screening and provide any interventions that may be needed, they're probably not medical, the better off you are. So we're looking to partner on that and to promote and partner on developing some home visiting for vulnerable families. So we also, in addressing the high needs, high cost members, again, as I was mentioning, that's a more like a short-term investment, right? If you're able to invest, remember that slide where I showed age, blind, and disabled, how many there are, how big the costs are? Well, that's where people are. If you're age, blind, and disabled, you have higher costs. You have very, very complex needs. They're not going to be the same, and we have to come up with different kinds of solutions in order to address it. Why? Because more than 20% of the healthcare expenditures are from the top 1%. That's a lot, right? That's a lot. Not a lot of people, but that's a lot of money going for a very few people. What we know is that there are evidence-based things you can do, we can do today with the appropriate will that make that difference, that create seamless, integrated care, bring down costs, and with improved health outcomes. So our priority initiatives here, again, are to use those evidence-based practices specific to high needs, high cost members, to target services for the chronically homeless. Chronically homeless have disability, they have complex health needs, and as my little diagram here is meant to show, the people who are chronically homeless can't get healthy with their complex health needs without housing, and they can't obtain or retain their housing without having their health needs met. And so that's why we have to have that partnership. We currently have a waiver amendment in for consideration with CMS. We just gave some bad news yesterday that it's been kind of crickets and not really good news coming back from CMS, but we're trying to, on our approach to serving the chronically homeless, but we're still optimistic that we'll be able to make the changes needed so that we can bring these services here and expand the services here to really help play our part in addressing the needs of the homeless in our state. We want to, again, provide those incentives for providing that care. And then lastly, I would be remiss if I didn't call out the focus and the expansion on focusing on palliative care and quality of life at the end of life. Again, those are really going to be very key elements in addressing individuals who have high needs and high cost and very complex health needs. Again, can't do any of this if you don't do payment reform and financial alignment. Just going to keep hammering at that. You got to change how we're paying for things. The thing is that we're getting exactly what we paid for. Exactly what we paid for. If you're sick, we'll pay you more. If you're sicker, we'll pay you more. Got to change the financial alignment to make this work. So currently with our Medicaid managed care plans, we do have some value-based purchasing requirements in the contracts. We'll look to evolve those to use more sophisticated models, more directive models of saying, okay, that might have worked before, but now our expectations are that you evolve the value-based purchasing models. We will work on different kind of incentives. We'd like to enhance our rate setting methodology to incorporate the social determinants of health to account for those risk factors, to help encourage health plans and providers to be able to provide care for those who need it the most, to pay more for outcomes, and then this last slide, which is a teeny tiny nod to Governor O'Malley's presentation, which is really to partner and engage with stakeholders to think about and develop a multi-payer models for services. So would we want to do something like that, like what Governor O'Malley was talking about for Maryland? Would we want to do that, something here? Medicaid should be one of the payers at the table. We are willing and able to come to the table and have those conversations. The last strategic initiative is to support our community-driven initiatives to improve population health. So why do we include this as an element? I think part of it is because of the recognition that ultimately all healthcare is local. It's local communities, local providers coming together, making those things happen within their communities. That's where it starts. There needs to be overarching vision, direction, but really it's community-driven efforts. We have many examples of that here in Hawaii that we want to build on. We have several highly innovative federally qualified health centers, community health centers. We have an excellent effort going on right now in East Hawaii through the Community First Initiative. There's actually many, many different initiatives that are going on right now that that we need to build on and support to the best way that we can. The one other thing on the support community-driven initiatives that I want to pull out that I haven't really talked about yet is the last two bullets. We do have 5 health plans here, and as a Medicaid doctor, as I go out into the community and I talk with different kind of providers, a lot of times they say to me, why is it that you have 5 health plans? Can you please make them go away? Can you just please have one health plan? And I think over the last couple of years, I've started to see, well, I've only been here 2.5 years. Over the last year, I've started to see some change a little bit in that. It's like, oh, health plans, they really are working with us. They really are supporting our community initiatives. So that's a good thing to see. But I do think that we are going to want to be thinking about what does it mean for 5 health plans to support one community initiative, right? What does that look like? And so that's kind of the innovative thinking and the creative thinking that we want to engage in with you and with those community partners in thinking about what this program and what we can do. And then lastly, and this is part of that, trying to streamline administrative functions as much as we're able to, so that you all aren't being driven crazy by administration. So what about these building blocks? Well, one of the basic building blocks is information technology, data analytics. There's lots of different things that are going on right now to support this. In fact, there was different sessions today that talked about it. I'm not going to call out a bunch of them. I'm going to call out the all-payer claims data warehouse, and our ability also in Medicaid to help create a Hawaii Health data center. We also want to call out and continue to support the health information exchange, continuing to address all the data sharing, legal issues, which are endemic to this kind of work. But we know we can do it. It's just a matter of sitting down, rolling up the sleeves, and making it happen. And then promoting common performance measurement and supporting data sharing across systems, not just health systems, but for example, I was talking about that homeless initiative earlier. Well, how do we identify who's chronically homeless? It's not in our data system. So, are there ways that we can share data with the homeless data system? So those are the kinds of things that we believe are essential in order to accomplish these strategic initiatives. Another is to build a workforce capacity. And this isn't just by training more and more doctors, although that's part of it. It's also helping physicians and clinicians to work at the top of the license. It's by providing support such as telehealth. It's by creating and investing in things like the community, the Project ECHO. It's focusing on and working on community health workers, integrated intensive case management teams. There's lots of different things and lots of different ways that we hope that we can support these efforts. It's also by supporting and to the degree that the Medicaid program can, to support the training systems, the graduate medical education, for example, and those training systems, the way that we can in what it means to be doing team-based care. What does behavioral health integration look like? Because if we want to, again, change the care, then you're also going to have to start doing your training different, because a lot of physicians today, they might have been trained. I'm trying to think of my dad who came out of the Mayo Clinic. Well, what the Mayo Clinic's programs look like today, they don't look anything like what they were when he went through training. So we want to help support that as well. And then the third one is by increasing performance measurement and evaluation. This is actually a requirement, a CMS requirement. We have to have this. We got to evaluate our programs. It's also really, really important to do that for accountability and transparency. So what does our waiver timeframe look like? Well, we're doing our work right now on getting the word out, doing public forums, sending out the document. We hope to submit the actual formal waiver application by the end of February. Then we have to negotiate it. It goes into effect on January 1 of 2019, and then the hard work begins, and that's when it becomes. And that's the end of my presentation today, and I certainly hope that you have lots of engaging, wonderful questions for me today. Thank you so much. It's been a pleasure.
All right, thank you very much. Let's sit down and I'll grill you for a few minutes. How's that? Here you go. Thanks, Judy. So this is a question I ask a lot of folks. I think it's probably perhaps more directly related to your work. But how are you finding, or how do you expect to find this state-federal interaction? Put differently, clearly the federal government is a partner in Medicaid, and the federal government has multiple opinions about Medicaid right now. How do you foresee this negotiation playing out over the next few months?
I think that the negotiations, I'm cautiously optimistic that they will be productive. Mm-hmm. I know they'll be robust. But I also know, this actually came up in a prior session, we are not actually asking for a bunch of money. We're not asking to spend money lots of different ways. That being said, we're asking to have the flexibility to spend money on things that, for services that aren't traditionally health services, so we'll see about that. There's more flexibility within managed care plans to be able to do that than there are in just a straight fee-for-service program. CMS has come down pretty hard recently and said, don't even bother asking for more money. So, but I think the kinds of programs that we're putting together that focus on the social determinants of health, I think will be positively received. And because we're not asking for more money, I'm hoping that they will go relatively well. That being said, our first foray into experimenting with that hasn't gone quite so as well as I had hoped. And so continued engagement is going to be a must. It is going to be challenging. That's to be expected, but I'm cautiously optimistic that we'll be successful.
All 1115 waivers are difficult and robust to varying degrees regardless of the administration. Seema Verma has been clear in spoken and written comments that she believes a work requirement is really a central component of what we should expect of Medicaid beneficiaries. What will be Hawaii's response when they say, where's your work requirement? How are you going to move these people off of welfare and back into the work environment?
Thank you for that question. Work requirements. At the National Association of Medicaid Directors, I was actually on a panel on that topic. And I was with two of my red state colleagues who have work requirements or are trying to have work requirements. What I said at that panel is that Medicaid actually has promoted employment for a long time. We have it as we have supported employment for our people with disabilities to try to help people engage meaningfully within the workforce. We have had supported employment we're trying to incorporate it for people with mental illness, because again, employment is actually one of those social determinants of health. But to the degree when it comes to requirements that then lead to the loss of coverage is not a value that we hold. We believe that access to health insurance should be available regardless of one's employment status. And so if someone is able to gain employment and meaningful employment and move off of Medicaid, we applaud that. But if it means that they are unable to gain employment and they lose their health insurance, that actually doesn't help anyone. It doesn't help the healthcare delivery system. It does not help the Medicaid program in the long run, nor does it help the overall health and well-being of the community, and certainly not of that individual. We would like to partner with the employment services. You know, it's like we can help make those connections. It's just that we would never predicate Medicaid eligibility on a work requirement.
There's some talk that some level of civic engagement might make sense. In other words, instead of a direct work requirement, that maybe it's a parent being active in his or her child's school, or some other sort of volunteer or civic engagement activity that shows that engagement and overall health is not necessarily about having a job, but it is certainly about being social and engaged in your community to varying degrees. What do you think about that notion, and is that a third pathway between work requirement and no work requirement?
So let me reframe. Okay. So health insurance, including Medicaid, should be available in our state. Health insurance and health coverage is considered to be a right. It's a value. And we've had it since at least 1974 with the passage of the Prepaid Healthcare Act. Medicaid program is one of those health insurance options. let's put that aside. Okay, health insurance, we want to make sure that it's available to whoever qualifies. We want to make sure that people have access to health insurance and health care. Can civic engagement, can employment, can those activities help people with their overall health? Yes, they can. And we would want to encourage, and in fact, when we're talking about helping or trying to promote incentives for managed care plans and for providers, that's somewhat what we're talking about, is what can you do to help engage people so that they can be engaged in not just their health and their health care, but also help and work with community partners on education, help with community partners on food and nutrition, or other forms of volunteering or civic engagement. We are also part of the Department of Human Services, so we partner with the Department of Human Services programs in those things. But again, we're not going to tie eligibility for health insurance or health insurance coverage to people's engagement in those other activities. Rather, we would like to promote their engagement in those other activities without them having to worry about their without having to worry about their health insurance. At the National Association of Medicaid Directors, I apologize for bringing this up again, but at that session there was a member panel for the very first time. The Medicaid directors actually had a member panel. We had 4 individuals who came in, and actually it was 5 individuals who came in and spoke about their experience of being on Medicaid. And 2 of the families had children with special health care needs. And Medicaid stepped in and provided health insurance when no other coverage was available, and covered transportation, covered expensive medications, et cetera. By having the access to coverage and to health insurance for those children, the mother and the dad were actually able to go back to work and be employed because they didn't have to worry about their access to their health insurance and losing it. I think is that kind of a situation that we would want to promote here, and not, hey, if you don't work or if you're not civically engaged, then we're going to drop your health insurance.
So we're coming to the end of a robust day, I think, in terms of conversations, and I want to ask you the same question I asked our opening keynote speaker, which is how can this audience, this community, the folks that are here and that will watch this online, how can we or they help you?
Oh, that's fantastic. Well, first of all, if you're interested in the vision document, please do let me know, and I will send it to you. We would like to know what you think of it, what ideas you may have that you didn't see or that you would like to see developed more in there. Medicaid program, it's not successful if it doesn't work with the community, with healthcare providers, with community advocates, with the public health. And so to the degree that we can engage actively in that, then that's the other way that that people can be helpful. And I think the third thing is, some of these conversations are going to be hard conversations. But I think we also, part of this engagement and part of how we all can be helpful to each other is by going into those conversations with a foundation of trust, and with that focus on the outcomes that we're trying to accomplish, which are healthy families, healthy communities, and overall community well-being for our state.
Well, we would be happy to forward that out to all 6,000 people on our Hawaii email list, so you can get a lot of feedback if you'd like. Judy Morh Peterson, Director of MedQuest, thank you very much for making time. Let's give a round of applause.